Hello, everybody. Thank you for dialing in to the lunchtime seminar today. It's with great pleasure that I introduce Samira, who will talk on the physical effects of anesthesia on the developing brain. We very much look forward to your talk, Samira.
Thank you very much. It's a pleasure to talk at this Wednesday lunchtime meeting. So some of you may have heard me do parts of this talk before, and it's an area that's interested me for a while. There's continual updates on it. So for those of you who have attended before, there's a lot of updates happening, and there's a lot that's new in this area. So I hope you'll still find it interesting. It also ties in quite nicely with the talk that one of my colleagues, Tom Hardy, is doing next week, where he's talking about the behavioral disturbances with anesthesia, and some of them the anxiety that actually leading up to the anesthetic has sometimes for months and weeks and months afterwards. So physical effects and then the psychological effects. I need to do that one. Yeah. Wrong one. Okay.
Oh, actually.
No. Something's happened.
Oh, yeah, there you go. Yeah. I just clicked it. Yeah.
Okay.
It'll work now.
Okay. So, as early as 1953 was when it was recognized by Dr. Eckenhoff, who's an anaesthetist, that there were definitely behavioral aspects and behavioral changes after an anesthetic. And he sent around a questionnaire to parents afterwards, asking their children about night terrors, bedwetting, sort of frightened of strangers, and demonstrated that there were definite changes in behavior and personality after a single anesthetic. Now, the early 2000s, so 2000, 2010 and onwards, the 2 decades of this century have been full of papers talking about the effects or the adverse effects of anesthesia on the developing brain. And then in 2016, the FDA put a safety label warning on all of the anesthetics, saying that having an anesthetic would basically affect the development of children's brains. And this was quite a big step. And we were afraid that parents would bombard us with lots of questions and they'd ask us for an official statement. They wouldn't want their child to have an anesthetic. But thankfully, our parents don't read the FDA statements very much, and so we didn't get too much of that. But we were still concerned, and we certainly had to provide a number of parents with the general APA warning. In 2018, they changed their warning slightly, and they've put in, I think, a duration. So they've put in an anesthetic greater than 3 hours or repeated procedures, that it may affect the development of children's brains. Having said that, it's not something we do on a regular basis. And just talking about this presentation today, I was talking to one of my colleagues, and we said, it's very hard to work this into a conversation. And if you say to a parent today that your child who's having their tonsils out or grommets put in or something else, a relatively minor procedure, they may end up, you might have a year long of night terrors, bedwetting. It's not quite the right time to say it. So we think that written information in the children's general anesthetic leaflet would probably be a good place where they can have a read about it in their own time. And if they have questions, they can ask us about that later. So the common anesthetic drugs, what do we use? So on one side, on the left side, you can see the table of drugs that we normally use. And it's a huge variety. We've got huge amount of, different classes of drugs, benzodiazepines, NMDA antagonists, alpha-2 agonists. We've got the induction agents, we've got volatile agents that are used in anesthetics. We've got a lot of different things happening. And the FDA put all of those drugs on the list. So there wasn't really anywhere to hide. You couldn't say that there was one drug that could be considered a safe anesthetic at all. So if we look at what are the mechanisms involved in this adverse damage or what, and there are lots of sort of lab models, and then we'll talk a little bit about the rat models as well as the as well. So there's apoptosis, for which ketamine volatile agents are particularly harmful, altered neurogenesis, degeneration of mitochondria, abnormal re-entry, cytoskeleton, and you get alteration of the dendritic spines as well. If we look at some of the papers, what came out and what was alarming, and I'll go through them relatively swiftly because I have presented them before, and what I want to talk now about is the new evidence afterwards. So they gave rats lots of ketamine. They gave them in huge doses. So they gave them doses of 25, 50, and 75 milligrams per kilo to day 7 rats. Now, day 7 rats apparently equate to the first 3 years of life in humans. So that's the first 3 years of life is a time when the brain is developing very rapidly. There are lots of synapses forming. There's lots of neurogenesis, and that's a really important time. And if that time something is affected, then it has long-term effects, and that sort of equates to day 7. So putting into context that this was 25, 50, and 75 milligrams, and then they said that it'll cause neuronal degeneration. So 25 milligram per kilogram, so normal rat brain on up here, and that's with some dead cells. So we would, as an anesthetic dose, if we were using ketamine as an induction agent, we would give a dose of 2 milligrams per kilo, and then probably none afterwards. If we were doing an infusion of ketamine, which some of our patients do get, it's usually of the order of 50 to 100 micrograms per kilo per hour. And you're hoping that some of that would be excreted as well. The next thing is in the non-human primates, you get isoflurane-induced neuroapoptosis. And if you look at them, there's a normal neuron on the left side, which is A, and then you've got this squiggly kind of dead, shriveled up kind of neuron on the right side. Obviously not normal. And that was isoflurane in a dose which we wouldn't use as normal, but it was a 5-hour anesthetic, and that caused neuronal death. Further ones, again, if you look at the rat brains, there's also altered mitochondrial morphogenesis. That was in 2011. That was a mixture of nitrous oxide, isoflurane, and benzodiazepines. If you give them desflurane, that's bad for them as well because that increases dendritic spine density, and that was 2010. And that was basically, it looked at all isoflurane, sevoflurane, desflurane for 30, 60, and 120 minutes. And then desflurane as well seems to be worse than isoflurane and sevoflurane. So then they looked at ways of how we could protect against neurotoxicity. There was a lot of work that went on that involved looking at people having an anesthetic without surgery, and it was deemed that if you're having an anesthetic for, let's say, a scan, which didn't involve a painful stimulus, that potentially that was actually worse, and there was something about surgery that was protective. And it might be the inflammatory response to surgery might have some degree of protection. So they looked at xenon as a pre-treatment, and xenon is a bit of an experimental drug. It's been around for at least 25 years that I've been hearing about it, but it's never seems to have made it into clinical practice. You could give them lithium. Again, not usual practice for pediatrics or anyone having an anesthetic. You could give them melatonin, and melatonin is a drug that has got, I think it engenders a lot of interest and is quite good as a pre-medication in some extent. But I think the long-term and widespread use of it has still not happened. Or you could give them erythropoietin beforehand. All of these are actually not really viable options for protecting an anesthetic, any toxicity. So then in 2009, there were some human studies. So what do we look at that? So although it was published in 2009, they looked at patients from 1976 to 82 in Minnesota. And these were children who remained in the community until 5 years of age. They looked at about 5,500 children, of which 593 received an anaesthetic before the age of 4. And children receiving 2 or more anaesthetics were more at risk of developing learning disabilities. This was in the Journal of Neurosurgical Anesthesiology, 2009, from the New York State Medicaid program. Children having a hernia repair before 3 years of age were twice as likely to be diagnosed with a developmental or behavioral disorder. And that also looked at about 400 kids with 5,000 in the community. This was a sibling cohort study. This was published in 2011, but between 1999 to 2005, again in New York State Medicaid program, the risk of being diagnosed with a developmental or behavioral disorder who had surgery before 3 years of age was 60% greater compared with a similar group of siblings. And then this was a slight game changer. This is where things started to turn. And in 2011, which was a Danish study looked at children from 1986 to 1990. And the Danish are very good at keeping records, and they have everyone's kind of academic scores, sort of GCSE, but actually it's year 9 academic scores are really important. So they had, they looked at nearly sort of some 2,700 kids who had a hernia repair, and they were compared with randomly selected 5% matched population, and they found that the academic scores were no different. Now, at this time, people were starting to think that we need something else. We need to do now, this is time for prospective studies, and maybe, you know, I think this was probably the point where things changed. At this point, there was still one more study. I think there was the PERT study that still came along, and this was in Pediatrics 2012. And they thought that they looked at about 2,500 children. They were assessed, of which 300 were exposed to GA, and they said that the exposed children had lower scores in receptive and expressive language. And while I was doing my fellowship, there was this big trial that was ongoing, and this was the GAS study. And everybody has been eagerly awaiting the results of the GAS study. And the full results of the GAS study weren't published until 2019, so last year. And they had 722 infants. It was a multi-center international, prospective study, which went across Australia, New Zealand, Netherlands, Canada, America, UK, and I think Italy as well. Again, hernia repair, it's one of those procedures that is a frequent thing in childhood, and you can assess it quite regularly, as well as cleft palates. But somehow the inguinal hernia repair seems to have been picked as a choice of surgery. Unfortunately for that, it means that you've got a predominantly male population. So they recruited patients between 2007 and 13, and the primary outcome was to look at the neurodevelopmental outcome at 5 years of age. They did an interim examination at 2 years of age, and that was because they thought that actually they're going to lose a lot of follow-up, and they were really keen to get all of them in. And they looked at secondary outcomes as well, and they thought they might find a reduction in apneas. So this was spinal, as in a local anaesthetic versus general anaesthetic. And the early outcome studies was published in, I think, 2013 or so, and they found no overall risk of increased apneas with a general anaesthetic. They had a small reduction in early apneas, which was considered less than 30 minutes with local anaesthetic. So that would be the time when the patient would still be in recovery. They had less interventions for the apnea in the regional anaesthetic arm. So they think that the severity of these apneas was not as bad. They did have a slightly lower blood pressure intraoperatively in the GA arm, but that was not deemed to be significant. And then, interestingly, the 2-year and 5-year follow-up showed that there was no evidence that less than 1 year of sevoflurane anesthesia in infancy would increase the risk of adverse neurodevelopmental outcome. So either at 2 years and 5 years. And it's been eagerly awaited. It's very reassuring to see that there's no differences, and so on. And then there was at the same time ongoing in, I think, America, they had the PANDA study, which was over 2009 to 2015. It was sibling matched cohort, 105 sibling pairs. And there were no differences. I don't think they matched this to inguinal hernia repair. I think this was all anesthetics before the age of 36 months. And they found no differences between the IQ of these children. And then there's been the MASK study. That's been in America, and they looked at quite a lot of children, 1994 to 2007. And this was the only one that looked at, this was, sorry about that. Just, yeah, it's probably one of those random calls. I would ignore it, Yincent. Yeah, I would just ignore it. Thank you. So they looked at, they had 1,000 children in the study. Some of them had a single exposure to anaesthesia and some of them had multiple exposures. Now they use, I meant to look up what OTB was. It was some, it's a type of assessment which they can do in animal models as well. Certainly non-human primates they can do. But it's to do with how quickly you do a task and how, how quick your processing is and how you can process multiple things at the same time. And there was no significant difference between the children who were exposed or had multiple exposures. So all of these three studies, widely awaited in the anaesthetic community, have shown that there were no differences in the children having a short anaesthetic. I think probably if I was to look back and say, I'd say that anaesthetics has gotten a lot safer. Whilst we might be using similar drugs to what we were 20 years ago, but we've gotten a lot better at using it, and we're, very good at measuring how much we give, and we're very good at measuring blood pressure and maybe actively treating what would have been a lower blood pressure. And maybe that was the one that was leading to some kind of cognitive deficit later. A little bit to be thought of as cautionary was that in all three studies, the parents reported worse outcomes, even in the local anaesthetic arm of the gas study, which is really interesting that they thought that their child's behaviour or processing or IQ was somewhat affected. Maybe they were expecting that it would be affected and they just went with that, or maybe there is a tiny difference that is we deem is not statistically significant, but actually is. And that most of these studies looked at male children. Now, I would probably extrapolate that information and say, if you look at male children, I think I could say the same for female children, but there could be differences there. The APA certainly has a statement that says that, we only give anaesthetics when they're necessary and that a short anaesthetic is safe, and if your child has any complex problems, to discuss it with the anaesthetist. But I think we truly do give anaesthetics only as a necessity. We do keep it as simple and short as possible. We try and have the surgeons available and ready to start when the patient is ready for them. Occasionally they go missing and there's a hunt the surgeon phone call happening at the time. And a short, simple anaesthetic, we should consider it safe. So I think personally for me, where I have probably changed my opinion over the last sort of maybe 10 years, where I would have maybe put off somebody having a small skin tag removal or a tiny procedure at the age of, let's say, 18 months. I would have said, just wait till they're a little bit older. I would probably say, no, actually, it is safe. It's fine to have your anaesthetic. And there doesn't seem to be anything that is alarming out there in the literature. There are millions and millions of children worldwide who have an anaesthetic every day. And if there was something big out there, we should have it. We have enough information out there that, should have told us that there was something wrong. So I think on the whole, it's safe. And that's it.
Excellent. Thank you. I just stop sharing now.
Okay.
Good. Okay.
And are there any questions there?
Yes. So, any questions for Samira?
Hi, Samira. You're right.
All right, thank you.
Is that something that you do put on the leaflets that you give parents prior to an anaesthetic then, or is that something that is not quite made it on there?
I don't think it is. Oh, it's been a little while since I've looked at our own leaflet. But I remember, so we talk a little bit about emergence delirium in the fact that, they might be agitated, but I don't think we talk about the effects, the longer term effects. And interestingly, Tom might touch upon that next week when he talks about the anxiety aspect and how the long-term effects of the anxiety might still be there afterwards, but that might be something to put into an updated leaflet next time round.
Brilliant, thank you.
Okay.
Excellent. Anyone else? I think Sadie's got a question.
Hi, Samira. What do you think about our frequent flyers? So, obviously, we have a lot of children who have multiple and quite long procedures in that stage of life.
Yeah, so, I've thought about it a lot, children so it's hard to measure because there are so many other confounding factors. I think on the whole, anaesthetics are very safe. I don't think that there's anything major to worry about. However, children who are in hospital very young, they're not having a normal life. A child who spends a great deal of their childhood in hospital being looked after by strangers and getting used to strangers, being stabbed regularly to have bloods taken, their whole perception and outlook on life is changed already, by the time they're 6 months old. That's not a normal upbringing. So I suspect that will have a part to play in it later on. I don't think it'll be the effect of the anaesthetic, but it might be just even the whole experience of coming to theatre, having the mask put on you, the whole disorientation at the time of waking up. That might have long-term effects. But probably the anaesthetic itself is not going to be of harm.
Excellent, thank you. Anyone else? On this. Can I have a question? Is there anything that is being done to protect the head, like cooling or anything like that? For very long procedures.
So for very long procedures, no. So we would definitely not cool in theatre. Actually, keeping them warm or normothermic is the aim because that helps with coagulation and all the other stuff. However, I think we've become more active at treating hypotension. So even in neonates, we aim for a slightly higher blood pressure than, say, would have been tolerated maybe 10 or 15 years ago. We have started using cerebral oximetry for our more, call it fragile patients. And often it is reassuring to have a good cerebral oximeter trace and a good number that makes you think that, okay, the brain's functioning really well. And so it is reassuring. So we've got better monitoring. We use BIS sometimes, especially with using TIVA anesthetics, to make sure that the depth of anesthesia is adequate and that we aren't over anesthetizing our children as well, and leading to the subsequent low blood pressure. So I think blood pressure is probably a key thing for keeping it safe.
Excellent, thank you.
Samira, do you think that there's any advantage to the children that are being sedated on PICU having the same kind of monitoring that they have in theatre?
When you say same kind, which one do you mean?
So, the use of the BIS if they're on propofol infusions and things. Do you think that would be useful for children that are on propofol infusions in the intensive care setting?
Possibly. So when I haven't done PICU or adult ITU for quite a long time, but when I was there, we would certainly have sedation holds every day, so to wake the patient up a little bit. And make sure they weren't over-sedated, and then so when the sedation restarts, it might be at a lower level, and it would be titrated to the child so that you make sure that they aren't over-sedated. But yeah, BIS could be. We've had a lot of redundant BIS machines recently.
Mm-hmm. Thank you.
Yeah, no worries.
Excellent. So any final questions? Frederick.
No, I don't think of a question. Thank you, Samira. I actually, it's a topic that I've never really thought about in much detail. So thank you for bringing something to the table that isn't maybe necessarily part of the work of non-anesthetists or non-PICU doctors.
Thank you.
Okay.
Excellent. So thank you very much for Samira for talking today. So Frederick, who's for next week?
Well, I think it's Tom Hardy. I think Samira already alluded to it.
Brilliant. That's good. So for everyone on call, just the last few days, we've sent a questionnaire about these Wednesday webinars. So please do fill it in. I'll try to send it out again at the end of the week if you've lost it. But thanks for dialing in, and we'll see you next week.
Thank you.
Excellent. All right.
Samira, if you see Tom, I'd like to have a title for his talk for next week, please.
Okay. Frederick, it is the effects of anxiety on children pre-anaesthetic. I'll send you an email.
Lovely, thanks. Because then we can circulate today.
Yeah, thanks.
Thanks, Natasha.
Bye.
Bye.